Stop for a moment. Just consider this fundamental metric. Before the 2008 financial crisis, the average funding increase for the National Health Service stood at roughly 3.7% per year. This was the necessary baseline, the established convention required to successfully meet rising demand, integrate complex new medical technologies, and adequately care for an aging, multi-morbid population. That was the political and medical consensus. But then the system changed. From 2010 onwards, that average annual increase plummeted to less than 1% in real terms. The tap wasn't just turned down, it was almost entirely shut off, deviating sharply from the historical fiscal rule. For over a decade, the NHS was intentionally subjected to what can only be termed a sustained financial starvation diet. The question is not if the NHS is systemically broken. That is, regrettably, a settled matter evidenced by unacceptable waiting lists and critical access delays. The critical question we must address is how, and perhaps more profoundly, why a political consensus developed around dismantling the functional capacity of one of the nation's most cherished and essential public institutions. The answer, as we shall rigorously analyze today, lies entirely in the legacy of austerity. Now let's define our terms precisely. Austerity is not merely cutting budgets on an ad hoc basis. In the realm of political economy, it is the process of fiscal consolidation, an ideological, often rapid, reduction of the national deficit achieved primarily through reduced public spending. Following the 2008 crash, the political justification was clear and relentlessly propagated. Britain had to balance the books and aggressively reduce its national debt to retain the confidence of international financial markets and avoid punitive bond yields. When the newly formed coalition government in 2010 set out its programme, the Treasury dictated that almost every government department would face significant real-term spending cuts. The NHS, however, was treated differently, or at least the rhetoric suggested it was. Politicians maintained the public narrative that the NHS budget would be protected. But, as we have established, to deliberately freeze an essential budget in a growing, complex, high-demand sector is, in functional reality, a structural cut. When clinical demand rises by 3.7% and your budget only rises by 0.8%, the result is the compounding of a structural deficit every single year. The deliberate ambiguity surrounding this supposed protection was brilliant political messaging designed to shield the policymakers, but it proved to be a disastrous mechanism for policy execution. It created a situation of predictable, yet managed, decline. Let's look at where this calculated underfunding was most corrosive. The true legacy of austerity can be distilled into three key areas of intersectoral dependency collapse: workforce, infrastructure, and social care. Consider first the workforce attrition. Austerity politics led directly to a protracted freeze on public sector pay and, critically, the abolition of the nurse bursary in England in 2016. The policy rationale was presented as increasing student intake and saving on university funding. The resulting data is unequivocally damning. Nurse training applications immediately plummeted, leading to an undeniable recruitment crisis years later. This short-sighted tactical saving created an immense exponential cost, forcing the NHS to rely heavily on expensive, high-cost agency staff to fill the resultant vacancies, a vast hemorrhaging black hole in every NHS trust's annual operational budget. The current crippling vacancy rate for nurses and doctors across the entire sector is not an unexpected outcome or an organic failure. It is the direct, measurable outcome of a policy choice made nearly a decade prior. Secondly, there is the issue of crumbling infrastructure. The capital budget, the critical money required for basic maintenance, state-of-the-art equipment, and new builds, was relentlessly raided and reprioritized to temporarily prop up the operational budget. Today, the NHS faces an astonishing £10 billion maintenance backlog, a figure that grows annually and represents a significant long-term liability. This is not about cosmetic refurbishment. This involves critical infrastructure, such as faulty electrical systems, failing heating and ventilation, and outdated surgical theatres. Hospitals across the country are literally crumbling around the patients and the dedicated staff, an obvious failure of capital stewardship. This structural neglect compromises patient safety and fundamentally hinders the delivery of modern effective medicine. But the third failure, the decimation of social care, is arguably the single most devastating piece of the austerity legacy. Local authority budgets, which fund essential social care and community services, were subjected to the deepest cuts, often reduced by up to 40% in real terms. The result? The social care system, the NHS's fundamental interdependent partner, was systematically decimated. If a patient is medically fit for discharge, MFD, they cannot leave the hospital unless a funded care package is successfully put in place at home or in a care facility. When social care funds are removed, these patients remain stuck in expensive acute beds. This phenomenon is termed delayed discharge, or more commonly, bed blocking. It paralyzes the entire system. No beds free upstairs means no patients can move out of the emergency department. No space in A and E means ambulances must queue outside. The collapse of social care, starved by austerity, is the precise structural reason your ambulance arrival time is now critically unacceptable. It is, of course, necessary to be intellectually robust and address the political reasoning. The proponents of austerity, primarily senior Conservative and Liberal Democrat politicians, argued that the national debt was an overriding existential long-term threat. They asserted that high debt would lead to punitive interest payments, crowding out all other forms of spending and potentially sparking a catastrophic market panic. The argument they put forth was one of grave necessity. There is no magic money tree. However, numerous leading economists counter that the pace and depth of the cuts were not only unnecessary, but were actually economically counterproductive. Instead of prioritizing fiscal consolidation during a period of low economic growth, they contend the government should have focused on stimulating the economy with targeted productive investments, what economic theory terms counter-cyclical spending. Crucially, critics argue that cutting health and education funding represents the most self-defeating form of saving. Every penny saved by cutting a crucial mental health early intervention program costs the state pounds later when that patient requires full-time, high-cost crisis care. The cuts to the nurse bursary led to spending billions more on agency staff. This pattern is a textbook case of short-term accounting, creating long-term structural economic ruin. It was, at its heart, an ideological choice to aggressively shrink the size of the state, cleverly disguised as inevitable economic necessity. So, what is the comprehensive legacy of this structural choice? The NHS was not broken by its staff, nor by intrinsic inefficiency, nor by the genius of its founding principle of universal care. It was broken by a relentless, decade-long program of structural divestment, a political choice known as austerity, which destroyed its capacity to function. The cuts were targeted not only at the NHS core, but at the supporting pillars, social care and professional training, which ultimately caused the entire edifice to collapse into the chronic crisis of supply and demand we see today. The NHS is currently in a state of managed decline. Reversing this devastating legacy requires a profound societal shift in understanding. Public services are not a discretionary cost to be minimized, but a productive national asset that underpins the health, productivity, and indeed, the moral fabric of the entire economy. Investment in health and capacity is not mere expenditure. It is, quite clearly, an economic multiplier. If this deep data-driven analysis of structural failure resonates with your desire for clarity on the state of the nation, I strongly encourage you to continue the investigation into class politics and the broader national landscape. Head over to our dedicated playlist for our full documentary series, starting with The Great UK Economic Betrayal, which connects this fundamental NHS breakdown to the collapse of real wages and the parallel crisis in education standards. We must stop asking for more money and start demanding better politics.